Thank you for introducing me. So good evening, dear seniors and colleagues. I am honored to introduce Dr. DALIM Kumar Baidya here to this ISA Malappuram academic meet. He is currently the additional professor, Department of Anesthesiology, Pain Medicine and Critical Care, AIMS, New Delhi. And he's also the assistant editor of Journal of Anesthesia and Clinical Pharmacology. Sir has done his MBBS in Medical College, Kolkata, and also pursued his MD degree from AIMS, New Delhi. So sir is also the editor of Washington Manual of Critical Care Medicine in South Asia edition. And sir has laurels of publications under him. He has around 150 publications, and in which 125 are PubMed indexed. His main critical interests are in critical care medicine and perioperative ultrasound, and also in perioperative outcome of his researches are based on that. And he also is interested in obstetric and pediatric anesthesia, and also in difficult airway. And sir is also a reviewer of in many journals, like journals of clinical anesthesia, journals of obstetric anesthesia and critical care, and also in IJA. He's also organized many CMEs, and the latest being in AIMS PG Assembly 2018 conferences, and also National Airway conferences in 2017 also. And so I'm honored to welcome sir. And today's topic is intraoperative ventilation strategy and postoperative outcome in major abdominal surgeries. And this abdominal surgeries being the most common in day-to-day practices, as we all anesthetists undergo, or we do. It's very important and very critical for us to know what is the ventilation strategy, so that it helps in the better patient outcome and early postoperative recovery also. And so anybody has any doubts, and please you can write in the chat box, and we will at the end of the discussion we will get to know about it more. And over to you, sir. Dalim, sir.
Okay, thank you so much. So at the outset, I would like to thank you for inviting me for this interactive session in this webinar. I'm really honored for that, and hope the session becomes useful for everyone. And I also look forward to learn a lot from your experiences and your knowledges. Okay, so let me start. So we'll be discussing the mechanical ventilation strategy in major abdominal surgery. So the brief outline of the talk will be the very basics of lung mechanics, which we need to understand to go through this talk, and little bit about lung protective ventilation strategies and its role in elective and emergency major abdominal surgery. So first of all, why we are discussing this topic, like what is the concern? So major abdominal surgeries, mainly I refer to laparotomies, open abdominal surgeries, has got various post-operative complications, and one of the major important complication is pulmonary complications. So we see this quite often, that post-operative period, these patients develop atelectasis, they require oxygen for a longer period of time, many develop pneumonias, or even few develop acute lung injuries or ARDS, and have a longer stay in the HDUs or ICUs. So it affects the individual patient outcome, and at the same time increases the cost of healthcare facilities. So it's important that we understand how to reduce this post-operative pulmonary complications. So there has been some good progress. For example, from the surgical point of view, a lot of surgeries are being done through laparoscopies. So this has significantly reduced the incidence of post-operative complications, mainly bleeding, and also the pulmonary complications. From the anesthesia front, there have been a number of evidences to show that epidural anesthesia in a major laparotomies has reduced the post-operative complications, including the pulmonary complications. So is there any role of the mechanical ventilation strategy that we use in the operating room? Can it influence the post-operative pulmonary outcome? So this is our first question. So if we think that yes, then we should go ahead and further explore what can be done better in the mechanical ventilation strategy that can reduce this post-operative pulmonary complication. So let us start with this graph. This is a very important scalar. Pressure in the y-axis and time in the x-axis. So this is a pressure time scalar of a patient who is on volume control ventilation. So in a patient of volume control ventilation, during inspiration, the airway pressure rises and reaches a peak airway pressure or peak inspiratory pressure. Then it reaches a plateau. If we apply an inspiratory pause, then there will be a plateau pressure and then it will decrease. And if we add peak positive end expiratory pressure, then the baseline will be above this lower y-axis. So this is the am I audible, right? And can you see the arrows also in the screen?
Yes, sir.
Okay.
Yes.
Okay, right. So just wanted to confirm that.
Yes, sir.
So the positive end expiratory pressure will keep the baseline elevated of the pressure time scalar, and peak inspiratory pressure and the plateau pressure. Now, most of the modern ventilators have the facility to apply inspiratory pause, which is by default set in 10%. We usually do not need more than 10% of inspiratory pause in a healthy lung. In ICUs, we many times give it more than that. So if we apply inspiratory pause, what happens? There will be no gas flow further. So no air will come inside and no air will go out. And at that time, at the end of inspiration, all the alveoli which are supposedly inflated, the ventilator will measure the pressure inside. So that will be called the plateau pressures. So the difference between peak pressure and the plateau pressure will be utilized to overcome the resistance of the airways. And this plateau pressure will be the pressure which will keep the alveoli distended at the end of inspiration, and PEEP is the pressure which will keep the alveoli distended at the end of expiration. So this concept is important, and the difference between the plateau pressure and the PEEP is what we call driving pressure. So basically during each inspiration, this driving pressure or the difference between plat and the PEEP is the one which is inflating the alveoli, and then at the end of expiration this driving pressure is gone, so alveoli come back to their the end expiratory volume, right? So in other words, the driving pressure can be considered as a pressure which is forcing the lung open and open during each inspiration. So the amount of lung strain which is occurring during each inspiration driving pressure can be considered a surrogate of that. Okay, so what happens when the lung compliance is less? For example, in the patient who is in ARDS. So if you look at this lower graph, the dotted line suggests the normal pressure time waveform. Whereas in a patient who has low compliance, compliance is basically, if you go by the formula, delta V by delta P. So volume difference divided by pressure difference. And the unit will be ml per centimeter of water. So the amount of volume that will be generated at a given amount of pressure. So when the compliance is less, that means you need to generate more higher pressure to distend the alveoli or deliver the target volume. So this curve will shift upwards in a patient who has decreased compliance. Now, we should understand the concept of lung heterogeneity. Now, this was initially described in the setting of ARDS, but this is not uncommon in the setting of major abdominal surgery as well. So, see, in the bottom of the screen, there is a set of alveoli which are persistently collapsed or atelectatic. Like during each inspiration and expiration, these alveoli are not getting inflated at all. So the amount of pressure generated is not enough to open these alveoli, and they are just contributing to further hypoxia, intrapulmonary shunt. Whereas there will be some alveoli which will be less open at the expiration and will be opened during each inspiration, and again during expiration they will come back to the resting stage. So they will open and close repeatedly during inspiration and expiration. There will be a lot of difference in the volume of these alveoli during each respiratory cycle. So this is what we call atelect trauma. So repeated opening and closure and significant amount of change in the volume of alveoli during each respiratory cycle will cause strain in the alveolar wall epithelium and can lead to atelic trauma. Whereas some alveoli of a well ventilated area of the lung will be already in a state of good expansion, which will be further over distended during inspiration, and these alveoli can be subjected to volutrauma or barotrauma. So in other words, entire lung, all the alveoli in the entire lung will not be in a similar stage. Some will be very close, some will be quite open, some will be in the middle of the volume status, so that there is possibility of variety of trauma occurring in a lung tissue. Although this is classical of ARDS, but there has been significant data to suggest that in major abdominal surgeries or even thoracic, open thoracic surgeries, this kind of heterogeneity exists in the lung tissues because of various reasons. For example, in general anesthesia, the FRC will be reduced and a lot of alveoli will be closed. Whereas in open abdominal surgeries, abdominal retractors will be placed that can cause significant compression of the lung tissue, particularly in the bases. And moreover, as the surgery progresses with time, there can be further lung injury, which is contributed by, say, transfusion of blood, increased use of crystalloids, or release of different cytokine mediators in a patient who is already in a condition of inflammation, or surgical trauma induced cytokine release contributing to further inflammation and inflammatory cytokine induced lung epithelial and pulmonary capillary endothelial injury. So all these molecular mechanisms take a toll on the lung tissues, and there can be significant lung dysfunction. So what happens? All these things lead to postoperative atelectasis and various other pulmonary complications. So that's why many times we see many patients following major abdominal surgeries, prolonged GI surgeries, will develop postoperative atelectasis, pneumonias, even few ARDS, pleural effusion, so all sorts of complications. Now, first, before we go on and explore whether any ventilatory strategy has any effect on this post-operative pulmonary complication, which I'll mainly refer to as POPC, we need to define what is POPC. Now, initial studies had generally referred to all these complications together as POPC, like ARDS, ALI, pneumonia, pneumothorax, pleural effusion, atelectasis, all these things. But there can be significant variation in the or institutional practice differences in the diagnosis of this complications, right? So there is a need to define POPC. So of late, this Melbourne group scale has been used and validated, which has got 8 criteria. So whenever we do any study of to find out post-op pulmonary complications, the POPC is identified based on these 8 points in the Melbourne group scale, which has got clinical parameters like fever, purulent sputum, or oxygen saturation less than 90%, as well as different laboratory evidences. For example, raised TLC, use of antibiotics, or sputum microbiology, X-ray findings of atelectasis or consolidations, or even a prolonged ICU stay is also one of the points. Prolonged ICU stay has been defined as, it is defined differently for different surgeries. For example, here for lung surgeries, more than 1 day stay, or for esophageal surgery, more than 2 day stay is considered prolonged ICU stay. So among these 8 points, if 4 points are there, that means POPC is present. So POPC is defined as at least 4 of this 8-point scale of the Melbourne group scale scoring, right? Okay, so we'll see first of all what is the role of lung productive ventilation. Now, it is a common practice. The conventional practice or the standard care, what we say, is to use trial volume of around 10 ml per kilogram. Previously, it used to be even higher, 10 to 12 ml per kg, along with no PEEP and FiO2 of around 0.5. So this used to be the general practice all over the world. Now, over a period of time, mainly deriving data from the researches done in ARDS patient, we have realized that there is a significant role of lung protective ventilation. So, lung protective ventilation means an open lung approach where we avoid repeated opening and closure of alveoli. So, we need to give some positive end expiratory pressure, and it is not a zero PEEP, rather some amount of PEEP which will keep the alveoli open throughout the respiratory cycle. Now, as far as the PEEP is concerned, how much PEEP we should set, that we need to know, which we'll call optimum PEEP. Now, what is optimum PEEP? The classical definition is PEEP at which the oxygenation will be maximum and there will not be any hemodynamic disturbances like no bradycardia, no hypotension. Now, how to titrate PEEP or what PEEP will be best for a patient, that we need to find out. The another important observation, we realize that the ventilator induced lung injury is mainly contributed by the tidal volume. So higher the tidal volume, more is the ventilator induced lung injury. So mainly we need to decide the lung protective ventilation strategy based on the a combination of a perfect tidal volume and a perfect PEEP. And if these two are good, then high plateau pressures will be avoided, right? So if you remember, the higher plateau pressure means more lung injury, more ventilator induced lung damage, right? So this is the first study actually which was done by the ARDS network, and it was published in NEJM in 2000. This is the first study which gave the concept of low tidal volume ventilation. So in this study, if you see, the conventional group had 12 ml per kg of tidal volume. This is all ARDS patient in ICU, and the intervention group had 6 ml per kg of tidal volume, right? And the plateau pressure was targeted less than 30. So in the ARDS, as per ARDS, like their goal was this much of PO2, SPO2, and this much of pH. Now it is interesting to note that the low tidal volume group had significantly less mortality compared to the traditional or the conventional group. Not only that, the other morbidities were also reduced. The number of ventilator free days were more, number of organ failure free days were more in low tidal volume group. So that means adoption of low tidal volume strategy with 6 ml per kg of tidal volume significantly reduces mortality and other morbidities as well in ARDS patients. So subsequently, since we see good incidence of POPC in major abdominal surgery, like if you look at the literature, the incidence of POPC following major elective abdominal surgeries will range from 15 to 25%. And in emergency surgeries, it will be further high, like 30 to 40, even 50% in some studies. So, so the next extrapolation of this knowledge of ventilation from ARDS were used in the operating rooms, and we try to find out, can lung protective ventilation reduce the incidence of POPC in abdominal surgery. So we'll go take one element of ventilation strategy at a time and see what has happened. So first is the role of tidal volume. This is a very important trial which investigated this research question. Was done by Improve study group. They randomized around 400 patients into two groups. One was the lung protective ventilation group, and another was the non-protective ventilation group, and all the patients were undergoing major abdominal surgery. And the outcome was again major pulmonary and extrapulmonary complications together, a composite, within first 7 days. So what happened? The protective ventilation group received 6 to 8 ml per kg of tidal volume, 6 to 8 centimeter of H2 of PEEP, and intermittent recruitment maneuvers. Whereas in the non-protective ventilation group, there was higher tidal volume, no PEEP, and no recruitment maneuver. So recruitment maneuver, for the purpose of these studies, most of the studies had defined it in a similar fashion: 30 to 40 centimeter of water of airway pressure, manual recruitment, persisting for 30 to 40 seconds. Am I audible?
Yes, sir.
Okay, right. So, so let's see what happens. This study came in NEJM in 2013. So, what happened? If you look at the different outcomes, this is the non-productive ventilation group, and this is the lung productive ventilation group. So the composite outcome by day 7 and day 30 all were significantly reduced in the protective ventilation group, like 10 to 12%, in comparison to non-protective group where it was 27 to 29%. Other secondary outcomes like incidence of atelectasis by day 7 were also significantly reduced. Requirement of NIV was reduced. Even duration of length of hospital stay was also reduced. So this study showed that we should ideally use low tidal volume ventilation, right? Like 6 to 8 ml per kg with some amount of moderate PEEP like 6 to 8 centimeter of water in major abdominal surgery patients to derive all these benefits. Now, what is the role of PEEP? Now, that study had combined tidal volume and PEEP both together in the productive group, and the non-productive group had higher tidal volume and no PEEP. So we really did not know whether the benefit was derived out of use of PEEP or out of use of low tidal volume. So a subsequent trial which was published in the Lancet next year, they investigated the role of high versus low PEEP in open abdominal surgery. So this is called a Provilo trial. So they did this study in 900 patients across 30 centers of Europe and Northern and Southern America, in all in open abdominal surgery. In both the groups, they used tidal volume of 8 ml per kilogram. In one group, they used PEEP of 12 centimeter of water, and another group they used PEEP of less than 2, that is 0 to 2 centimeter of water. And the primary outcome was postoperative pulmonary complications by day 5. So what happened, if you see, there was actually no difference in the composite incidence of POPC or individual component of pulmonary complication, no significant difference at all in either of the groups. Whereas in the high PEEP group, there was significantly high incidence of hypotension and use of vasopressor drugs. So this study clearly shows that such a high PEEP, arbitrary high PEEP in all patients is not beneficial. So PEEP as high as 12 centimeter of water should not be used. So from there the question comes, how much PEEP we should use? That we really do not know. So is there any role of individualized PEEP or personalized PEEP? So we need to titrate the PEEP in a particular patient and find out what will be the optimum PEEP for that particular patient. So how can we do that? So the best way to do, whenever you have a machine which shows driving pressure or a compliance, then the best way to do is to titrate the PEEP to a lowest driving pressure or the maximum or the highest compliance. So that means that will be the best possible PEEP at which majority of the alveoli will be a similar stage and the heterogeneity of alveoli in the lung tissues will be reduced maximally, right? So before we start doing that, we need to find out what is the from the available literature, what is the data which shows that really a low driving pressure useful or not. So that research question was addressed nicely in a meta-analysis which was published again in Lancet Respiratory Medicine 2016. So this was an individual patient data meta-analysis. That means they had accumulated data of all the individual patients from the master charts of all the included randomized control trials and did a statistical analysis. So they included all the studies which used all the RCTs which compared conventional ventilation versus lung productive ventilation and reported the driving pressure in their results. So it was 17 RCTs, 2,250 patients, and this was all these studies. These authors have included abdominal, thoracic, and cardiac surgery patients. So now see how the studies were. These were the all studies, and if you look carefully in these two columns, one is the protective group, another is the conventional group. So in the protective group, you see the most of the studies use tidal volume in the range of 6 to 8 ml per kilogram, whereas in the conventional group, these were 8, 10, 12 ml per kg. PEEP was in the protective group in the range of mainly 8, 10, 8 to 10, some studies 5, whereas in the conventional, no PEEP or even 2, 3, if couple of studies 5 PEEP, right? So now what is the driving pressure? So these studies, the protective ventilation strategy groups of all these studies, if you see, the driving pressure was in the range of around 10, like 12, 13 or 14 maximum you will see. Whereas in the conventional, you will see quite high driving pressure being reported from some studies like 18, 24, 20, 19, 22, 16, 15, like that. And there are a variety of studies, mainly abdominal, thoracic, and cardiac. So what is the outcome? So basic idea was to find out whether the driving pressure value influences the postoperative pulmonary complication or not. So if you look at this graph, this gives the adjusted odds ratio or the risk of development of pulmonary post-op pulmonary complication, and this was the data from different studies. So in the studies where PEEP was low, or say with PEEP titration, there was no change in driving pressure. The odds ratio were around in the range of 1. That means no gain, no loss. Whereas the studies in which the driving pressure decreased with increase or titration of the PEEP, driving pressure decreased. That means more and more alveoli are getting recruited and lung compliance is improving. That had a low odds ratio, almost towards 0. That means the risk of pulmonary complication is decreased significantly. Whereas in the studies where the increase of driving pressure was noticed with the titration of PEEP, the odds ratio coming as 3. That means 3 times increase in the chance of development of POPC if the driving pressure increasing when you are titrating the PEEP. So this study give us a this meta-analysis of all these RCTs give us a very good level 1 evidence that in patients having abdominal or thoracic or cardiac surgeries, intraoperative high driving pressure and change in the level of PEEP that result in high driving pressure are likely to be associated with more postoperative pulmonary complications. So this gives us an idea of how to titrate the PEEP. So previously we just knew that a PEEP at which oxygenation will be very good, but will not cause bradycardia or hypotension. But that is a very crude way of assessing the PEEP. Like, you cannot titrate PEEP minutely on the basis of this data, because over a wide range of PEEP the oxygenation may be similar, but what changes are occurring in the respiratory mechanics at the level of alveoli will not be sure. So this change in the lung mechanics in the form of change in the compliance or the driving pressure gives us a reasonable good amount of knowledge on that. So next we should find out whether PEEP or driving pressure guided PEEP titration will be beneficial or not. So for that, we performed this study in our institute in, again, elective major abdominal surgeries, which are mainly the GI surgeries, long surgeries. In this study, what we performed, we recruited 82 patients in 2 groups, the fixed PEEP group and the titrated PEEP group. So the fixed PEEP group received 6 to 8 ml per kg of tidal volume, PEEP of 5 and no recruitment maneuver. Whereas the titrated PEEP group received 6 to 8 ml per kg tidal volume and titrated PEEP to lowest driving pressure and no recruitment maneuver. Now recruitment maneuver we did not use because by this time there is some data, or I would say good data, which suggests that there can be significant lung injury with the use of high pressure recruitment maneuver. So so we avoided recruitment maneuver in both the groups. So what happened, just to tell you about the titration method, after the induction of anesthesia, we incrementally, at that time we kept PEEP of 2 and then incrementally set the PEEP by 1 centimeter of water of gradual increments and noted the driving pressure, and we found out that at what driving pressure, at what PEEP the driving pressure is lowest. If further incremental PEEP starts, the driving pressure causes the driving pressure to start rising, then we'll again reduce the PEEP from that level. For example, from 2, if we increase 1 by 1, like 3, 4, 5, 6, like that, and once we increase the PEEP by 1, we'll allow 10 respiratory cycles and then measure the driving pressure by applying inspiratory pause. And then again increase the PEEP by 1, like this. Suppose at the PEEP of 8, I see the driving pressure is coming down to 12. But then after making the PEEP 9 or 10, driving pressure is again start rising. Previously, suppose it was for 14, 15 or 16, at PEEP 8 it came down to 12. After PEEP of 9 or 10, it is again going up back to 13, 14. So that means the lowest driving pressure of 12 was achieved at a PEEP of 8. So I'll keep the patient at PEEP of 8. So this is what we did in the intervention group. And we assess the post-op pulmonary complications as per the Melbourne group scale, as well as we saw the blood gas data, and in the lung ultrasound also, by the use of lung ultrasound scoring system, whether the patients were developing post-operative atelectasis or not. And since we did in major GI surgeries, which used to run for 5 to 6 hours, we repeated the PEEP titration method every 2 hourly. Because as I was saying, with ongoing surgery, prolonged surgery because of blood loss, tissue trauma, cytokine release, IV fluid, transfusion, all these things can cause some amount of lung injury. So whether the optimum PEEP or the individualized PEEP for that patient changes during the process of surgery or not, we wanted to assess that, and that's why we did it intermittently every 2 hours as well. So grossly, if you look at the results, the red part of the bar are showing the fixed PEEP group, and the blue part are showing the titrated PEEP group. So if you look at the individual complications of the Melbourne scale, the incidence of each complication was higher in the fixed PEEP group, as denoted by the red part of the bar, whereas the complications were less in the the titrated PEEP group. So overall, there was 17% risk reduction of post-op pulmonary complications by the use of titrated PEEP group, and this was statistically significant. So this study shows that PEEP titration based on driving pressure in patients undergoing long duration major abdominal surgery should be beneficial. Now, already it is established in ICU setup in patients of ARDS. Now, these studies establish this in major abdominal surgery patients. So, is there any other study which have investigated the same question in other type of surgery? Yes. There is a recent study in anesthesiology which used the same strategy in thoracic surgery patients who are undergoing one lung ventilation. So they randomized patients into protective ventilation group, where trial volume of 6 ml per kg and PEEP of 5 centimeter of H2O was used. Whereas the driving pressure group, the conventional group, was also called protective ventilation group, because by this time this protective ventilation has become the standard of care there. So the driving pressure group, they used individualized PEEP titrated to the lowest driving pressure, right? And the trial volume was used the same, 6 ml per kg in both the groups. And the primary outcome was incidence of POPC by day 3. So if you see, the incidence of POPC was significantly reduced in the driving pressure guided PEEP group compared to the fixed PEEP or the protective ventilation group. So as the incidence of major complications like pneumonia and ARDS. So in thoracic anesthesia patients undergoing one lung ventilation also, there may be some role of PEEP titration based on driving pressure compared to a fixed PEEP strategy. Now, is there any evidence in emergency abdominal surgeries like emergency laparotomy? Yes. This study we had designed actually initially in the line of the IMPROVE trial, where we used in the lung protective group trial volume of 6 to 8 ml per kg and PEEP of 6 to 8 centimeter of water, along with intermittent recruitment maneuver. And in the conventional group, we used 10 to 12 ml per kg of trial volume with no PEEP and no recruitment maneuver. Basically, in our institute data, we had assessed that the incidence of POPC is very high in perforation peritonitis patients who are coming for emergency laparotomy. It was in the range of 40 to 50%, which was very high. So, we wanted to assess in emergency laparotomy whether adoption of this strategy can significantly reduce the complications. However, the results were not very encouraging, but I can say a little bit encouraging. So you can see the incidence of POPC was reduced to around 42% in group 1. One is the lung protective group versus the conventional group. It was 53%. So there was around 10% reduction in the incidence. However, this did not attain the statistical significance. The other individual complication rate or the ICU length of stay did not differ significantly. So when we analyze the data further, we realize that one aspect could be relatively less sample size. Another aspect could be the average duration of surgery in our this study was 120 minutes in one group and 130 minutes in another group. So these were not really long duration of surgeries. Plus, we excluded patients who had already pre-existing lung disease because we thought that will be a confounding variable. So patients who had known respiratory disease pre-existing were not included. So in emergency laparotomies, again, there should be more trials to really find out the role of low tidal volume and the optimum PEEP, or whether we should go ahead and do driving pressure guided PEEP titration. But if we extrapolate data from elective abdominal surgeries, then yes, we should go ahead and do it. But there is no literature so far available in the emergency laparotomies like trauma or perforation laparotomies. Now, what can be the effect of FiO2 on post-op pulmonary complications? Now, we have a general idea that very high FiO2 may cause pulmonary atelectasis. And at the same time, many times we tend to use higher FiO2 in surgeries, like, for example, in emergency laparotomies or in thoracic surgeries in particular. Plus, the confusion has been added because of another aspect, that there has been some data, although not very robust data, but some data which suggests that the incidence of surgical site infections can be reduced if intraoperatively high FiO2 is used. And based on the initial studies, WHO has loosely recommended that higher FiO2, that is, higher means more than 0.5. So initial studies which were performed with the use of FiO2 to find out surgical site infection rates used 0.7 or 0.8 FiO2s. So WHO has loosely recommended that use of high FiO2 may be considered to reduce the incidence of post-operative surgical site infection. But the anesthesia community was really worried about this because high FiO2 may increase the incidence of post-op pulmonary complications. So a few studies, or a lot of studies, were undertaken after that. And recently, the meta-analysis of these trials, which compared high versus low FiO2, has been published in JCA 2021. So the trials had used high FiO2 as 0.8 at least or above, and low FiO2 0.5 or below. So if you look at the complications rate, there was actually no significant difference in the complications, post-op pulmonary complications like pneumonia or respiratory failure or ICU admission or length of hospital stay, something like that. But the high FiO2 group had increased incidence of post-operative atelectasis identified in the basis of X-rays or lung ultrasounds. And also the post-operative partial pressure of oxygen was significantly low if high FiO2 was used. So although the crude complication rate is not increasing, but there is tendency to increase complication by reduction in the PaO2 as well as increasing in the incidence of atelectasis. So therefore, the high use of high FiO2 is questionable in major surgeries. However, I should tell you that this meta-analysis had included trials on all surgeries. It's not specifically for abdominal surgeries. All sorts of surgeries were included. So for the time being, we really do not use high FiO2. We use FiO2 of less than 0.5, like 0.4 to 0.5. Then another question comes to our mind very often, that many times after adopting such a good ventilation strategy throughout the surgery, at the end we put the patient on manual mode and open the APL valve and see if the patient is breathing or not. So the pressure inside the alveoli suddenly drops to zero, and that can cause significant atelectasis, right? So this question was addressed in a study, whether this manual assisted extubation versus pressure support ventilation guided extubation, which one will be beneficial? Now, in ICU setup, there are good number of studies so far which had seen that just before extubation, even if the patient has passed the spontaneous breathing trial and satisfied the winning criteria, just before extubation, if we keep the patient in pressure support ventilation for some time and extubate the patient on PSV versus where we are keeping the patient with low pressure basically on a T piece, or in the OT where we open the apial valve and keep it. In the ICU setup, the PSV guided extubation has found to have better oxygenation rate in the post-operative period and less chance of further complications, respiratory complications. Now, very recently in the anesthesiology, this research question was addressed, and what they did is that they randomized the patients into two groups: the pressure support ventilation guided extubation versus the control group, where intermittent manual assistance was given to the patient's own breathing efforts. And they did not do it in open abdominal surgery. It was done in laparoscopic colectomy and robotic prostatectomy. So note that they chose two important surgeries which are done laparoscopically in Trendelenburg position. In fact, robotic prostate is done in strip Trendelenburg position. So these are also the group of surgeries we should have some caution that they can have significant postoperative atelectasis, because not only because of pneumoperitoneum but also because of Trendelenburg positions. So the results were that the duration was just around 8 to 10 minutes only, the time required from the end of surgery till extubation. But during short time of pressure support ventilation guided extubation had significantly reduced the incidence of lung atelectasis. The atelectasis was measured based on the lung ultrasound scoring method, and the incidence of atelectasis was 33% in the PSV guided extubation group versus 57% in the manual assisted extubation group. And also the PaO2 was higher in the PSV guided extubation group, and these two were significantly different, statistically significant. So this study suggests that the incidence of post-op atelectasis and the oxygenation will be worse in patients who are not extubated over PSV guidance, right? So so grossly so far we have learned about the tidal volume, about the FiO2, about the role of PSV during extubation, and the role of PEEP titration based on the driving pressure or the compliance guided PEEP titration. Now it's important that we know which patients to select. Should we use all these strategies in all patients coming for abdominal surgery? I don't have the answer, but of course, in certain high-risk groups where the chances of POPC is high, we should always use it. So a wonderful scoring system has been devised, which is called ARDS score. This has been devised based on data on a lot of patients, 1,624 patients. And they, based on the multivariate analysis, they found out what are the important risk factors, and based on the odds ratio of risk factor, they gave risk score points also. And this has been advised to be followed in patients coming for surgery where you want to assess the risk of post-op pulmonary complications. So we look at the risk factors. Higher age will have higher scores. Like age more than 80 will have a very high score of 16 points are added. Higher the points, more the score means more is the risk of POPC. If the preoperative oxygen saturation at room air is anywhere less, patient had any respiratory infection in the last month, or patient coming for upper abdominal surgeries or intrathoracic surgeries, they will be giving very high risk scores. Similarly, the duration of surgery, if it is more than 2 hours or more than 3 hours, then the score risk score increases significantly, and emergency procedures are also giving higher scores. So if you calculate this scores and find the cumulative risk score is more than 26, that means the patient is at very high or intermediate risk of development of post-op pulmonary complications. So in such high risk groups, we should adopt a ventilation strategy which is likely to reduce the incidence of postoperative pulmonary complications. So to summarize, we should ideally identify the risk of POPC by ARDS scoring and adopt a strategy of low tidal volume in the range of 6 to 8 ml per kg of predicted body weight. Predicted body weight you can calculate from height-based formulas. And PEEP, ideally we should individualize the PEEP rather than using a low PEEP or a high PEEP or an arbitrary PEEP. The PEEP should be titrated ideally to the lowest driving pressure or maximum compliance. FiO2 should be used ideally less than 0.5, and we should consider pressure support ventilation guided extubation. However, if you assess the strength of the recommendation, these two, the low tidal volume and titrated PEEP to lowest driving pressure, these two should be very strong recommendation. The other two, although it does not have strong recommendation, but these are suggestions that we should ideally try to follow this. Thank you.